Yeah, I'm going to talk about some uses of experience sampling and sort of building it around some clinical questions that we were asking. And I suppose an overall theme that we have is thinking about ADHD in adults as a kind of mainstream mental health problem. And part for that is maybe traditionally in the early years, ADHD might have been thought of as mainly a behavioral problem or possibly a pure cognitive problem. But actually, when you meet people with ADHD, what you discover is there's a lot of what I just think of as common mental health symptoms that are also part and parcel of ADHD. And there's been much less work in trying to understand discriminating between ADHD and other conditions by focusing on individuals' own accounts of their symptoms, their sort of subjective psychopathology, if you like. Part of the background for this is, as you all know, ADHD is commonly seen to co-occur alongside other disorders. And this was the recent study from FIAD doing a kind of review of surveys that included comorbidity. And you can see that the majority of people with ADHD have one or more types of comorbidity, particularly anxiety and depression kind of stand up. And they're quite interesting because in the genetic studies, a condition that seems to show one of the strongest, or the mental health condition that shows the strongest genetic correlation with ADHD seems to be anxiety disorders, depression and anxiety disorders in particular. So it's interesting to try and understand that in a bit more detail. And there are many symptoms that people with ADHD describe, which are on their own sort of rather non-specific. Emotional instability, which we'll come back to specifically. Sleep problems, feeling restless, talking too much, chronic low self-esteem, finding it hard to concentrate, being distractible and impulsive, and this kind of mental restlessness that I will also focus on in this talk. So these are very common forms of psychopathology, and in a way, on their own, they really don't discriminate between different types of mental health conditions. So we have to go into things in a lot more detail to sort of see, well, where are the similarities, where are the differences. Just to show you the problem that clinicians often face, that we know is that many of the patients that we diagnose with ADHD have previously been diagnosed by a clinician having another mental health disorder. And so how does that come about? And so this very briefly just gives you a quick idea about that. But ADHD is like anxiety because they describe kind of constant excessive mind worry. And when they're worried about their performance in their daily life, this can look a lot like anxious worrying. They often feel overwhelmed, they feel restless, and they might even avoid situations ADHD is a problem, like waiting in a queue or giving a talk like this. And they have sleep problems and mental restlessness. So taken together, this looks like anxiety. Depression because of chronic low self-esteem and unstable moods, being impatient, irritable, poor concentration, and sleep disturbances. I'm going to talk later about a study comparing ADHD with borderline personality disorder. And of course, the confusion there could be quite substantial because they're both chronic psychopathologies that kind of stem out of childhood and adolescence. They can be behavioral problems, emotional instability in particular, and impulsive behavior and developing poor social relationships. And finally, we have conditions like bipolar disorder, where you also will get restlessness and overactivity and sleep disturbances, but in particular, mood instability, which, as you'll see, is also part and parcel of ADHD, and other things like ceaseless mental activity that can look a lot like thoughts racing. You can also get in bipolar disorder. So there might be particular ways of thinking about ADHD symptoms, which actually are quite hard to capture and aren't so well studied in research. But one thing we know in ADHD is when you say they have a problem focusing or have an attention deficit, in fact, they can hyperfocus. And it's almost one of the core characteristics of the attention deficit ADHD is it's more like a regulation problem, where they're either hyperfocused on the task or they completely lose their focus. And what they find difficult is sort of regulating and controlling that process. So it's very difficult for somebody who's depressed, who, you know, when they're depressed, they just can't focus, whereas an ADHD can usually focus on some things some of the time. So this sensitivity to salience and reward is particularly interesting. And people with ADHD often say, I get bored quickly and then I lose my focus. And they have other types of symptoms like feeling impatient when they're waiting. And a very common description that I'm going to go on to in more detail is excessive, uncontrolled, spontaneous mind wandering, which many people with ADHD say is causing them impairments in their daily life. So it's possible that that symptom on its own might be a cause of impairment in daily life. So I was working with an artist called Kai Sing Tun, and she was fortunate to have her artwork published on the front page of the British Journal of Psychiatry. And this was her image of her own mind wandering. She actually made this as a tapestry that you could hang on the wall. So it was great that they recognized the importance of this very subjective aspect of ADHD, experiencing your mind wandering all the time. And when we read the literature on mind wandering, in fact, there's a lot known about it in terms of the basic neuroscience. And we wrote a review article that sort of really tried to draw a parallel between mind wandering in people without ADHD and ADHD itself, and kind of saying that a lot of the same processes involved in mind wandering in the healthy non-ADHD population were the same processes that were disrupted and caused uncontrolled mind wandering in people with ADHD. And we had a kind of model where these brain dysfunctions, I mean, essentially we think mind wandering is due to a dysregulation of default mode network activity. And what we do know is that the default mode activity is very sensitive to the degree of mind wandering. And when it's very active, you're mind wandering a lot. And when you try and focus on a task, the default mode network is deactivated and other task positive networks come online. And so that enables you to focus. But it could be that if these processes are disrupted, you have this uncontrolled type of mind wandering, and that may lead to problems within attention in daily life, and could also lead to problems like performance deficits on cognitive tasks, like reaction time variability, for example. So we talked a lot to patients with ADHD and asked them, what is this mind wandering like? And there seem to be three key aspects. They said to us that their thoughts were on the go all the time. Their thoughts jumped or flitted from one topic to another, and there were multiple lines of thoughts at the same time. So we made up a rating scale that captured this. And this is just one summary paper. This was a large sample of about 1,500 people, and just looking at basically doing some analysis to look at the structure of the data. What we found is that this is a single factor and it's invariant across age, sex, having ADHD or not having ADHD. It's a very robust construct. And as you can see from these factor loadings, you know, that it's extremely strong across all the different components of mind wandering. So at least we think it's a single construct, and we believe it's what we call spontaneous mind wandering. And it's very different from kind of problem solving in your head in a kind of useful, productive way. These are random, unwanted thoughts that just pop up in your mind and disrupt you and draw your attention away from what you're doing. If you just take this rating scale measure and you just look at the correlations between this rating scale measure of mind wandering and the core symptoms of inattention and hyperactivity and impulsivity, you'll see they're very high. They're about 0.7 or so. It also links up in particular with impairment. And we did another analysis showing that the strongest predictor of impairment was mind wandering. So even after controlling for the effects of core ADHD symptoms, inattention and hyperactivity and impulsivity, there was still a main effect of mind wandering on impairment. And in fact, it was the best predictor of impairment on its own. The two red bars are actually another scale that was created measuring these different types of mind wandering: deliberate, which is more like a controlled, focused type of mind wandering in your head, which is quite useful, and this sort of spontaneous, uncontrolled type. And you can see that what ADHD patients were described was related to the spontaneous type and not at all with the deliberate type. I wouldn't like to give the impression that mind wandering is only seen in ADHD, and of course it's a very common feature throughout psychiatry. And in particular, you will see it in depression and anxiety, where you get kind of ruminations of particular depressive type. And there was a very nice model from Christoph et al., who had a dimension along the horizontal axis. So I can't see all my slide. I've got a thing overlooking it. But this bottom dimension is really going from being kind of having very goal-directed thoughts to having very uncontrolled types of thoughts, like excessive mind wandering and daydreaming in an uncontrolled way. The other dimension they call automatic constraints is much more about the content of thought. And so in ADHD, for example, the content seems to be almost any old thought, whatever is normal for that person. Whereas somebody who is depressed, the content of thought is very constrained and is kind of full of negative, sort of focused, ruminative thoughts on negative themes. So they're very different in terms of their content. So we can argue that they're both high in terms of internally generated mind wandering. But ADHD has very unconstrained thought content, whereas depression is kind of over-focused on negative themes in a ruminative type of thought process. So I'm going to come back to that in a minute. And the other key thing we were interested in that patients with ADHD describe is emotional lability. And of course, emotional lability is also very commonly seen in ADHD. One of the first studies, well, not the first study, but what happened in the history is emotional lability was always thought of as part of ADHD, and in more recent times, it sort of got lost from the diagnostic criteria. And it was Barkley and Fisher in 2010 who kind of reminded everybody that actually it was a core part of ADHD. And in this study, it was a follow-up study of children with ADHD to the age of 27. And you can see that if they use a rating scale measure, that what they called emotional impulsiveness, this blue group who still had ADHD at the age of 27, compared to the red group who'd grown out of ADHD and the green group who had never had ADHD, you can see they were very high in terms of being impatient and angry, frustrated, overreacting emotionally, and also losing their temper and being easily annoyed in particular. And he controlled for those effects in a regression analysis and showed that emotional instability, as he measured it, had a significant effect even after controlling for inattention and hyperactivity and impulsivity. And so he said it was a key part of the disorder and was as much a component of ADHD as the two traditional dimensions. And this is one of the measures that's being used to capture emotional lability in clinical trials, for example. And it sort of measures these different components like affective lability, temper control, and then overreacting to things emotionally. And if you pool the available data from clinical trials of drug treatments for ADHD, what you see is there's an average effect of about 0.4 on emotional instability, from the drug treatments we use for ADHD. And I think this is something that most clinicians will know, because when you treat people, they're more focused, they're calmer, and their moods are more stable. A lot of people said to us, but this emotional instability you get in ADHD might just be due to comorbidity. It might be because they're anxious and depressed and nothing to do with ADHD. So one of my students, Caroline Skiro, at the time, collected a sample of patients with ADHD who absolutely had no comorbidity as far as we could measure it. It was a very hard sample to collect, and she screened a total of 508 men to get a final sample of 41, where through a very rigorous process she'd excluded the possibility that they had another mental health condition. We decided to focus only on men just because we thought there may be sex differences when we measure things like emotional instability, and we didn't want to confound this particular analysis. If you just take rating scale measures, you won't be surprised to see that the ADHD group scored much more highly on measures of emotional instability on rating scales than a control population. And that's essentially what this data shows. But we were interested in looking at this in more detail. And so we thought Caroline had the great idea of using an experience sampling approach. And this was some years back, and we didn't want to interrupt people from what they were doing. So we asked people to wear a watch which vibrated at varying intervals throughout the day. In fact, it went off at roughly 1 hour intervals throughout the working day. And we did this over 5 days to capture a kind of typical working week. And then they would record at that point in time how they were feeling. And the question would be something like, how do you feel right now? Do you feel frustrated or angry or irritable? Or do you feel happy or excited? And they had to, there was a sliding scale, and they had to rate themselves anywhere between 0, not at all, or 100 being extremely high. We also asked them whether anything good or bad had just happened to them, to kind of see whether there was a reaction to good or bad events. And one way of displaying this kind of data is to use what you could call a heat map. And so this is a heat map of anger. And each row on this heat map represents one individual. And the color coding just means the darker the color, the more angry they are. So the black means they're most angry. And if you take the person in the bottom row, you can see that for a period of time, they got quite angry for some reason. But actually, most of the time, they're not angry at all. And if you compare the two groups, the ADHD group at the top and the controls at the bottom, you can really see there's a big difference. The ADHD group, there's much more black boxes. They're getting much more angry, much more often. And it's also much more speckled, and that means they're going up and down. There's much more instability of the mood, as well as a greater intensity of the mood. So this is the kind of data that is being generated using experience sampling in this study. And we can look at the other types of emotions, and you get very similar images. So in her statistical analyses, Caroline was able to look at this in a bit more detail. I haven't actually put all the key values on here. But what we essentially found is there were much bigger effects for moment-to-moment instability, which is on the far top right, rather than the intensity. So the changeability there was a bigger effect of changeability than the intensity. And the intensity was particularly for the negative moods. And in fact, happy and excited were not significantly greater in ADHD, although they were significantly more variable in ADHD. The bottom one actually shows when they said something bad had happened to them. And if you take the healthy controls, you can see there's not much reaction to their response to something bad happening to them. Whereas in the ADHD group, their emotional symptoms go up and appear to take about 2 hours to kind of get back down to normal again. So these were interesting studies, and the other analysis we were able to do is if we controlled for events in daily life, it seemed that we couldn't get rid of the emotional instability. So we concluded that the emotional instability in ADHD was partly reacting adversely in an exaggerated way to an event in your life, but it seemed that there may be a sort of automatic endogenous component as well. So there was a degree of instability that couldn't be solely explained by reacting to events in daily life. And we're hoping to do more studies on that. Out of that study, we then moved on to another study done by another student, Tala Mukhtarian. And we really wondered whether the type of emotional instability you get in ADHD, is that any different from the type of emotional instability you get in a disorder like borderline personality disorder, where we know that emotional instability is like a core symptom of the disorder. And so it was a very similar methodology. In fact, we tried to use exactly the same measures and exactly the same timing so we could make a direct comparison with the older data. The main difference was that we had more advanced vibrating watches, and now we were using kind of more advanced technology in terms of the mobile app, but the questions and the timings were all the same. And again, showing you a very similar image to the previous study, looking at a heat map of irritability in healthy controls. In women, this is now a study just of women, in women with ADHD, in women with borderline personality disorder, and in women with both conditions. And I suppose the question is, if you stand back and just look at that image, what's most apparent? And I think it's fairly obvious that all three clinical groups are very different from controls. So they're getting more irritable, much more irritable more often, and it's going up and down much more frequently. Can you see a difference between the ADHD group and the borderline group? Well, I think if you have a good eye for colour, you might see that the borderline groups are slightly darker on average. And it does come out that there is there is a small difference in the intensity, although the degree to which they're going up and down, the frequency of going up and down is very similar. And in fact, the amount of overlap in the intensity of irritability in this example is really huge. So at the individual level, if you met somebody with ADHD with severe emotional instability, you really wouldn't be able to tell the difference between them and somebody with borderline personality disorder based solely on the type of emotional instability they were describing, or at least in terms of the frequency and the intensity. This was actually a study from Ebner Prima that kind of also showed how the affective instability in borderline personality disorder can't be easily distinguished from a host of other conditions. He's looking here at valence and distress. This was a rather different study because the ratings were done every 15 minutes throughout the day. But you can see there's much greater valence and distress from these experience sampling ratings, but there's no difference between borderline personality disorder and post-traumatic stress disorder and bulimia nervosa. So, you know, it does appear that emotional instability may be a truly transdiagnostic construct that doesn't separate out one condition from another. That's not to mean to say the treatments could still be different, because it might be that in ADHD you need a stimulant, and for another, and in depression you need an antidepressant. And so it could be a little bit like having a fever. You need to know what's causing the fever to kind of fundamentally treat it. Although it could be, of course, that there are some generic treatments that help everyone, like anti-inflammatories. So, of course, you know, it doesn't tell us, you know, we can't say it's definitely the same pathology just because they all have the same type of emotional instability. So that was the main work we did with emotional instability. And now I just want to come back to thinking again about mind wandering, because on this app, we were not only asking them about their mood symptoms, but now for the first time, we introduced a new set of questions asking people about their ability to focus in daily life. Are you focused on what you're doing, or has your mind wandered off and you're focusing on something else? In this slide, we're just using our rating scale measure of mind wandering. And actually, I think we were surprised at the time. We expected ADHD would show greater levels of mind wandering than women with borderline, and we didn't find that at all. You can see that the mean effect is much higher in all three clinical groups than the controls, and there really is no difference between the clinical groups. So they all show this spontaneous, uncontrolled type of mind wandering. So when we used the experience sampling, we used a range of different questions. Some of them were binary questions, like number one, what are you thinking about now? Are you thinking about what you're doing right now? Are you daydreaming about something else? Or has your mind drifted off and you can't remember what you were thinking about at all? And this separation into these three categories is quite interesting, because prior data showed these correlate with default mode activity. And when you're focused on what you're doing, the default mode is at its lowest activity level. When you're dreaming about something else, it's more active. But when your mind's drifted off and you aren't aware of it, your mind wandering is at the highest level. So it's this very interesting linear relationship between the kind of degree and type of focus and mind wandering and default mode activity. Item 2 is interesting because we asked about the content of thought. Are you dreaming, if your mind is wandering, are you thinking about something pleasant or unpleasant or something neutral? The other questions are on a scale of 0 to 100. And so these are continuous measures where we ask very similar questions in the same way. Is your mind on what you're doing right now? Are you thinking about many different things at once? How hard is it to stick your thoughts to one thing at a time? Do thoughts keep popping up in your head? And it seems to be a related phenomena, this idea that I just cannot switch it off. This sort of mind wandering is uncontrolled and you can't switch it off. And if you look at the correlations of the experience sampling data we collected in daily life across these continuous measures, the inter-item correlations are all around 0.8 to 0.97. So what this is telling us is these are highly reliable measures. And even if we're asking the question in somewhat different ways, these are highly correlated measures across time and one with each other. And I think we also know that from the neuroscience literature, which shows that subjective accounts of mind wandering have a very strong link to default mode network activity in real time. So there's great utility in actually using experience sampling, not only to measure changes in daily life, but actually to measure changes that are occurring in real time in an fMRI scanner or with an EEG neuroimaging approach going on at the same time. You can also see that these experience sampling measures of mind wandering correlate very nicely with our rating scale measure that people sort of did as a one-off rating. And so there's quite a lot of cross methodology validity, if you like, between the rating scale measure and kind of relating it back to experience sampling taken 8 times a day over a typical week in daily life. What we found is that when we use the experience sampling data, as with the rating scale data, we got equally high levels of mind wandering in ADHD and in borderline personality disorder. So it completely replicated the rating scale data. And the other thing to say is that there's no effect of instability of mind wandering. So the amount to which mind wandering fluctuates up and down was actually exactly the same in the clinical groups as in the control group. So the only difference is the mean quantity of mind wandering. You're just in a mind wandering state more often. But the fluctuations, there are no differences from controls. In this analysis, we're controlling for anxiety and depression because we hypothesized that the mind wandering measure in borderline might be explained by anxiety and depression, but would not be, but in ADHD it would be accounted for by a core cognitive deficit. And this is what we found, that this isn't a very nice slide, but if you just look at these p-values in red, when we're comparing ADHD versus controls across these experience sampling items and controlling for anxiety and depression, the effect remains. But when we control for anxiety and depression, the effect in the borderline groups disappears. Interestingly, that was also true in the comorbid group. So it did seem that you could separate them out, and it kind of comes. And then the other question that relates to this is asking people about the content of your thought. And what this is showing is that the ADHD group has a very similar level of pleasant thoughts to control, whereas the borderline group has less pleasant thoughts, and the ADHD group has less unpleasant thoughts than the borderline group, and again they're very similar to controls, whereas the borderline group are different. So in terms of the content, in terms of pleasant and unpleasant, ADHD is behaving just like healthy controls, whereas borderline is quite different in terms of the frequency of reporting my thought is unpleasant rather than having a pleasant thought. So this kind of takes us back to this idea that there are these different types of mind wandering, and you can show this using rating scales, but also with experience sampling. And it kind of links back to this model that we discussed. Because what I wanted, I've talked about experience sampling in daily life. In the mind wandering literature, it's been used extensively during a cognitive test. So, for example, you're doing a sustained attention task, like a go-no-go task or a continuous performance task. And then at roughly 1 minute intervals, you're interrupted and with a probe question. And the probe question, the one that we used, said, are you focused on the task? Has your mind wandered off? Are you not focused? Has your mind wandered off and but you know what you're thinking about? Or has your mind wandered off and you weren't aware that your mind had wandered off? To capture these three different levels. And there's a number of different sorts of studies we're interested in doing. And I'm just going to talk about what we call context regulation. But the other studies are also very interesting. There's a link between saliency and reward, which essentially means that when you're doing something more interesting or more salient, you become more focused. And people with ADHD are particularly sensitive to that, to the extent that they can only focus when the condition is rewarding. So we're hoping to use experience sampling of mind wandering to investigate the impact of salience and reward on mind wandering and on brain function. The other thing that comes out of the mind wandering literature is called sensory decoupling, and this is also very interesting. These you pick up on the EEG, and this is the early P100, 100 milliseconds after a visual stimulus. There's normally a signal in the sensory cortex representing the visual stimulus on the screen. In ADHD, that seems to be deficient, and you get a reduced P100 response to a sensory stimulus. And this isn't particularly well studied, but there are a few studies looking at this, and we've recently seen that's what we also find in our own data. It's relevant to mind wandering because in healthy people, when you're in a mind wandering state, you have reduced sensory cortical activation, and the P100 is damped down when your mind is wandering. And when you're focused on the task, these sensory effects are much stronger. So it's kind of an interesting idea that, again, if ADHD is stuck in a mind wandering state, there it's not only a cortical problem. There's a kind of, sorry, it's not just an executive control problem, but there's a fundamental sensory deficit going on at the same time. But anyway, I'm going to focus on context regulation. And the idea of context regulation is that the frequency of mind wandering depends on the difficulty of the task. And this was demonstrated by Smallwood in his group, where they have a task under two conditions. One is a straightforward reaction time task, and the other is a condition with a working memory component, where in order to do the task, you have to be much more focused. And so what this shows is that in the difficult condition, there's a reduction in the frequency of mind wandering. Although you'll see at the individual level, although there's a significant difference at the group level, it is interesting to note how much variability there is at the individual level. And of course, this possibly could be accounted for, like different trait levels of ADHD in this population. So we took that task and with experience sampling probes, and we ran this in people with ADHD and a matched control group. And this is looking at the frequency of mind wandering measured using these experience sampling probes. And you'll see there's an absolutely huge difference between the ADHD group and the control group, particularly in the easy condition. They're mind wandering 60 to 70% of the time, and the controls, it's more like 10 to 20% of the time. We actually hypothesized that in ADHD, they wouldn't be able to regulate this. So when they did the more difficult task in the orange blocks, they would not be able to to reduce their mind wandering. And in fact, we were just wrong. So there is a significant impact of the task condition on mind wandering. But even so, it goes nowhere near the level of the control group. What we could also show is that these various conditions and also the frequency, so if we look at the actual performance measures, like mean reaction time, in particular reaction time variability shows a large case control difference here, and also the error rate. I don't want to talk about these in detail, but the key point here was that if you control for mind wandering frequency, these effects on cognitive performance entirely disappear. So this was consistent with our overall arching model that we're interested in, which says that it could be that mind wandering is a core pathology of ADHD, and the performance deficits on cognitive tasks could be secondary to the frequency of mind wandering. And this data at least is consistent with that, although it's not a causal model, of course. But at least it was consistent with that basic idea. I wanted to show you one last study, which was a very nice study by Katia Rubia's group, where they were doing a very sustained attention task. There were increasing delays between the stimuli of either 2 seconds or 5 seconds or 8 seconds. And the longer you have to wait, the harder it is to keep focused. And so if you take healthy controls and you look at their cortical activity, their executive functioning, their attention network activity, what you see is that as the task difficulty increases with increasing delays, there's a stepwise increase in the activation, in this case, of the left middle frontal cortex. The ADHD group are entirely different. Here we're looking at the precuneus, which is part of the default mode network. And similarly, as the task gets harder, it's harder to keep focused. The control group have to down-regulate their default mode network to keep doing the task at the same level of performance. But the ADHD group, if anything, kind of show increased default mode network activity. And we thought, okay, these things may well be reflected in the frequency of mind wandering. And so here now we're doing the same task, but we're looking at the frequency of mind wandering from experience sampling probes. And what we again see is that the ADHD group are mind wandering 60 or 70% of the time. Controls are only mind wandering about 10% of the time. And there's also a delay by group interaction, which effectively means that under the 5 and 8 second delay, there's an increase in mind wandering in the ADHD group, whereas in the controls, in fact, there are no differences. And the only possible difference is at 8 seconds, but actually that wasn't significant. So the controls are able to keep their mind wandering down and also keep it at a low level under these different task conditions. The ADHD group are mind wandering while doing the task. And then when the task gets harder, they mind wander even more. So, and again, these last slides show that the performance deficits associated with this task, like reaction time variability and mean reaction time, were accounted for by the mind wandering frequency. This last slide I'm not going to go into because it's a whole new topic, but just to say that if you start to measure EEG measures, you also see case control differences. And what's particularly interesting is, again, they are explained by the mind wandering frequency. The mind wandering frequency seems to be, at least if you try and account for it, it explains the case control differences, both in cognitive performance and also with these EEG measures. And so that's really where we've got to.